So this will be a little less interactive, and we're trying to kind of cover a lot of information here in about a 15-minute timeline. But Angela and I are here to talk about the emergency department. My name is Chris Haight. I'm a medical planner and designer here.
Already introduced myself, but again, I'm a project architect and healthcare planner.
So we're going to talk about the emergency department as the front line of care. And why is this important? For me, I'm a frequent flyer of the emergency department, as many of my colleagues know. And a reason for that, excuse me, technical difficulties here. It's going to advance. I'm a weekend warrior, heavy sports enthusiast, and with that comes some injuries that I can't stay out of the emergency department because of. But with that, I think it's really an understanding that for most folks visiting a hospital, this is often their first experience about the hospital system. It's a perception of the brand, and it's a perception of the patient experience and the care that that brand offers. So part of this discussion, we're going to talk about three models, some important considerations to understand about those different models and different ways to deliver care, and understand that this is not a one-size-fits-all approach. So the ping pong model. Okay, we're going to start here with something that we fear, and it's the emergency department's worst nightmare. We've all experienced an ED that looks a little something like this. Patients sitting in a waiting room, it's overcrowded, they're stressed out, they're wondering, am I ever going to see somebody to get care? Some people are even leaving before they are seen. From a clinical side, clinicians are stressed out. They're like, I can't get people through fast enough. I can't get them the right care when I need to. It's just a stressful time. And a lot of the reason for that is kind of the way the delivery system is set up. So it's sort of based around this mindset where I have a waiting room. I may see someone when I walk in who's not necessarily a clinician. They're maybe a registrar. I go to a triage room to get assessed to figure out why I'm here. I get bounced back to the waiting room. I may go back to another room to talk about, see how things are progressing. I may go back to the waiting room, and eventually, if I'm lucky, I get to the ED, go through that process, sit there for a while, I get assessed, and hopefully get out the door. Big part is that we get clogging points, and the average length of stay as part of that can be upwards of 384 minutes. Think about that, 6.5 hours of patient time in an ED. Not efficient, not lean. So we know that as healthcare systems, we've been going away from this model for years. The studies have been out there in lean strategies and really trying to push away from that. So the next one we're going to talk about is one strategy that we're using as a case study. It's an unbuilt strategy, but it's using this mindset about care initiation. The big thing here is looking at how the patient funnels into the emergency department from a whole and really looking at lean perspectives as part of that. So from 2 points of entry, whether it's the AMS entry or it's the patient walk-in entry, I have clinical eyes on the patient from all aspects of that process. We've all heard probably the mindset thrown around for the last 10 years, one-way flow, get them in, get them out through that process, and we really looked at trying to shorten our ALOS. But what this starts to utilize is getting the patient towards the center so that the unit can essentially flex forward and backwards depending on staffing, time of day, peak volume hours, peak season hours, and is sort of centered around this kind of mindset of utilizing results waiting or inner waiting spaces and using a 3-ring approach. So case study we're going to look at is at a health system in Louisville, Kentucky. It's a 29,000 square foot ED renovation that's proposed, not built yet. But the mindset here was it was based around a 46,000 annual visit caseload. So with that, we're roughly 42 different types of exam spaces. The real premise here is utilizing different types of exam treatment zones. So there is some results waiting, or what we're going to call, what you're going to hear Angela talk about in terms of vertical bedding, as well as the sort of universal style care room from an ED perspective. We're using triage as a way to kind of funnel that so it can flex as a universal style care room during peak demand. The premise here is kind of simple. Funnel them into 2 points. Unit can flex forward and backwards depending on the ESI level of the patient. So my 1s, 2s, and 3s can end up further towards the back. My 4s and 5s, if they do show up, which I'm 4 and 5, I get into that results waiting area. I need to go to an x-ray or an imaging piece as part of that, and I'm back out the door. Length of stay is shortened, Patient experience is awesome, great experience at my emergency department, even though I didn't want to be there in the first place, right? But the premise here, again, is from a staffing perspective, how does that work? So the concept, again, this three-ring approach, staffing happens at the center, patient care is sort of that next ring, the tertiary ring is my support spaces. This is a huge cultural shift. We're used to sort of emergency departments that are, it's decentralized nursing zones that have bookended by support in the middle. There's a lack of conversation between the clinical team in terms of their cohesiveness across and how they're delivering care. Patients kind of feel like they're lost in a maze within the emergency department. So really here is trying to open up that nursing core and get what I need for staff to do their jobs effectively in the middle, right? It's visual sight lines for staff to be able to have collegiate conversations across that area. Patients can see the staff. I have access to the staff. We can start to have that conversation and support the meds, the sort of immediate nourishment things I need are there, but we're using them in transparent manners. The sort of more heavy support that I'm going to need is on the perimeter with shortcuts to get there.
Now I'm going to talk about the immediate bedding model. So just like the care initiation model, immediate bedding tries to get those clinical eyes up front, but where it deviates is that there is no triage. Triaging is occurring when that patient walks into the hospital and is being seen by clinical eyes at the front desk. From there, determination is made to either send them into a vertical care or horizontal care. So your ED has been split into two tracks that the patients can move through. So the vertical care, it has many names: fast track, vertical care, super track, rapid care, but it all comes back to you're trying to keep patients who are the ESI level 3, which is the vertical 3, through 5 in a vertical treatment zone, so in a chair, in a recliner, instead of in a bed that needs more space. Like care initiation, you're also utilizing the results waiting space. A secondary space is a patient's just there waiting for some results. They're basically ready to be discharged. They're not taking up a treatment zone. So we are testing this out at a hospital outside of Chicago, and again, it's been proposed. It's not built yet. We're hopefully going to finish up CDs soon. But this is a smaller community hospital that has about 28,000 cases. It's about 11,000 square feet for the ED. But as you can see, we've got the two tracks. So in yellow, you've got your vertical care at the front entrance by your walk-ins, so your patients can come into your vertical care zone, back out, and the results waiting is being managed by your vertical care. In the back of the ED, these are your ESI levels 1 through 3, and this is where the ambulance entry comes in, and you keep it in the back away from the high traffic zone. Likewise, for support space, the general support space, clean, soiled equipment, is being clustered in between these two tracks, whereas localized supplies such as your meds, which you need rapidly, are placed within each of the zones in the department. Like the care initiation model, cultural shift is huge. How do you get everyone on board? In this hospital, this came from some lean training they did, as well as the head of their ED really wanted this immediate bedding model where patients just move in. There's no waiting, there's no triage. Now, when we went and talked to the users, they weren't quite sold on the idea, so we actually had to walk step by step on their operational flow. When a patient comes in, what is happening on these steps, and to get buy-in back from them. In the end, we still kept one triage room, just in case you're at a census capacity. You do still need to triage patients occasionally to determine when you're full, who's going to need care first. So what does that vertical care space look like? You can see it's much smaller than your universal style patient care room, but there's still plenty of space. The patient is being treated with appropriate care, but their family still be able to be with them. Likewise, this space feels a lot less intimidating if you've just brought a kid in for a bump on the head. This feels a lot better than a full-blown ED room that could be treating someone in cardiac arrest or something like that. Likewise, patients who are vertical tend to move quicker out of your ED once you lay them down. No one wants to leave. So that's another benefit to this. So some considerations.
So as we kind of talked about this, there's a lot of things to consider in terms of how we go about and strategize what we're going to do with our emergency department. And the big thing is we need to understand the demographics of the people that we're caring for. Right? What percentage of those folks are being actually admitted to the hospital? What is their average length of stay that we currently are operating at? what are we trying to improve? Anecdotally, had the opportunity to walk through a health system in Cincinnati. Within their administrative suite, they keep a tracking board. And on that tracking board is the ALOS. And they are tracking it by minute per patient every day, 24 hours a day. So, I mean, if you think about it in terms of that efficiency, in terms of how you're improving your organization and it's part of your culture, right, that is their bottom line. It's based on the patient experience, get them in and get them out. Happier patients, they'll come back for other services long term. And you need to understand what your population of patient is now and what it's going to be in the future. We heard Ken kind of talk about some of these strategies that, the next 30 years is going to be a different type of patient experience, and then what's the next 30 years after that, right? So how are we really going to start to focus those service lines? Is our ED going to become a service line centric? The one case example we showed in Louisville is their primary bread and butter is neurosciences as part of their emergency department. So really focus on stroke care as part of the ED. If you always do what you've always done, you always get what you've always got. Okay, so I think it's a good adage because there is a huge cultural shift that takes place that needs to be addressed as part of going through this process. And some ways to do that from our end, we had to kind of walk users through of what is the day in the life of a nursing staff or a clinician as they're having this conversation, right? Using tools like VR and using virtual reality to be able to walk them through from staff station to giving care to a patient, and what does it look like through the lens of the patient? What's the experience as part of that, right? How do I be able to interact across those transaction points, and what does it look and feel like long term as part of that?
And so how does that translate into some hardline metrics? So your average length of stay. Stanford went ahead and renovated part of their ED to feature vertical care spaces. Before they did this, your patient had an average ALOS of 384 minutes, as Chris said, 6.5 hours. That's a long time to be in the ED. Usually patients start getting cranky at that point. After they renovated to the vertical care space, they dropped that down to 270 minutes for patients in the vertical care zone, for a savings of 114 minutes per patient. Well, when they took that and multiplied it across their study over 6 months, so it's about 2,700 patients, that tallied to 213 patient care days that they saved by utilizing vertical care spaces in their ED. In 213 days, I would love to have that much time back in my day to keep working on other things. So that's a huge savings. That's moving more patients through your space, getting the care they need faster, and hopefully having a happier patient at the end. So that ties into the patient experience. When your patient comes into the ED, what are they thinking about when they move through your space? They're thinking about empathy. Do they care about me? Do they care about my well-being? Quality of care. Am I receiving the proper treatment in the proper space? And the experience of place, which Joe and Shar are going to talk about later. And so what does that end up being when you're being ping-ponged around through the waiting room, to the triage, to the back of the waiting room? I might have left without being seen, which is not safe and not a good thing for your company to have, or am I being moved immediately into clinical care and receiving the treatment I needed and hopefully quicker? So as the Barrel Institute, which focuses on patient experience, says, the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care is what you're trying to focus on as that patient moves through the space. FGI also plays into this. So as we all know, FGI is the minimum guidelines that you need to care for a patient in a certain space. And we've been seeing that horizontal patient care, single patient room, whether it's the bariatric or the single patient. And so the minimum 120 square feet, everyone knows the minute you put stuff in that room, that's more like 130, 140 to care for a patient, especially in a universal style room where you need to be doing everything in that room. So in 2022, FGI is proposing to allow for the vertical patient care space. It's the low acuity, your 3s through 5s, and you can see the scale, 40 square feet is all the space they're saying you need to care for a patient of that acuity level. And where this is happening is sometimes people think of FGI as this rigid box you can't get out of. FGI was never intended to limit innovation, but it's finally catching up with it. So what we want to ask you is, once you're trying to change your care model, where does that patient need to be treated? Is it in this room? Is it in a chair in a smaller space? Is it in neither of those? Is it just waiting for your results? So it really impacts the overall design of the facility. And with that being said, we understand not one size fits all. Whether you're a large hospital in an urban environment, being a trauma center, or you're a local community hospital, these models, and there's some other ones out there we didn't cover, but it may work for you, may work for another person, may work for both of you. But you really need to look at your system and the population and the culture you have in the system and decide from there. But all in all, we want you to understand that you need to treat the right patient at the right place with the right resource at the right time. So, thank you.